and members of Maharashtra State Chapter ISA who have joined this very important webinar today evening. The webinar is on regional anesthesia, and there are two important topics that we are going to discuss. One is the pericapsular nerve block, and who else will speak better than Dr. Sandeep Diwan on this topic. Another important topic of debate is perioperative cognitive dysfunction, whether regional anesthesia prevents it or it worsens perioperative cognitive dysfunction. We have two eminent speakers, Dr. Preeti and Dr. Pallavi, to speak on that. So without wasting much time, I think we should start our topic because our platform is full and all are enthusiastic, all are eager to listen to Dr. Sandeep. So I hand over the mic to Dr. Anita.
Yes, I want to welcome Dr. Bharti, who is the chairperson for this. Welcome, Dr. Bharti Adhe. She has done, Varsha, please share her CV. Yeah, Madam Bharti Adhe is alumna of GMC Nagpur, from where she has done MBBS and MD anesthesia. And then she joined Sancheti Hospital, Pune as a consultant. And she is there since 1997, working as a chief anesthesiologist for Sancheti Hospital, and her special interests are anesthesia for joint replacement surgery, high-risk anesthesia, and anesthesia for deformity correction. She is also interested in holistic approach to the patient, where regional anesthesia is combined with modalities. Welcome, Dr. Bharti, madam.
Sir, please introduce.
Good evening to all. It's my pleasure to introduce Dr. Nasima, who is well-known to this vicinity of Maharashtra. She is being a hardcore teacher in Krishna Medical College, Karad, and she is holding the present position as a professor of anesthesia in the Krishna Medical College, Karad. She is a postgraduate teacher, and she is one of the founder member of City Bench of Karad, ISA City Bench of Karad. And being a hardcore teacher, she had many publications, and a postgraduate teacher, many publications in the national and international journals. Thank you so much, Nasima, joining with us on this platform today. And let's see.
Thank you, sir. Thank you very much, sir. And thanks to Manisha madam and her team for inviting me to moderate this session. Thanks a lot, madam.
Thank you, Nasima. Thank you, Sari sir. Good evening, everybody. Good evening. It's my pleasure to introduce our today's speaker, Dr. Sandeep Diwan. I think he doesn't require any introduction. He is MD and DA. He is a pioneer in regional anesthesia, and now he is consultant and academic director, Department of Anesthesiology, and consultant pain management specialist at Sancheti Hospital, Pune. Today's topic is how I do it PNG block. I request Dr. Sandeep Diwan sir to deliver his lecture. Diwan sir, please.
Can you hear me?
Yeah.
Yes, sir. Yes, sir.
And can you see my slides?
Yes.
Yeah. So thank you very much, Dr. Manisha and Dr. Avinash, for those kind introductions. If you can please mute yourself, and you can be off the video because that might cause some problem with streaming. But it's going to be on you if you want to be. So as rightly introduced by Dr. Avinash, who is an old friend of mine, I have worked with him in some time. So regarding the block, as I said, the pericapsular block, what we know so far. So I've asked questions myself. Most of the times I do that. When you have a new block at your disposal, you need to do that. So let us see what it has in store, particularly regarding postoperative analgesia. When you look into this particular factor, it has to have a high quality evidence, which the femoral nerve block and the fascial block does have. It reduces the dynamic pain, and also within 30 minutes. MRI has proved the cephalad spread of local anesthetic, and it does soaks the femoral and the lateral femoral cutaneous nerve, but the obturator is not soaked, or it's not at all blocked. So why there is so much obsession for the obturator nerve? Now, whenever you have a lumbar plexus block or any other block for lower extremity, we always look upon whether the obturator nerve is blocked or not. Though it has got just 57% of absence of cutaneous distribution, and it just has the or innervates the adductor muscles. In spite of that, we still mention that the obturator nerve needs to be blocked for to have a complete blockade of the lumbar plexus. Now, this is some of the areas which has been proved by some of the authors, and this is the one which is by the recent author Bowes, and he mentions that this is the only part which is innervated by the obturator nerve. While the femoral nerve, you can see that it's the whole of the anterior part of the capsule, while the medial part is innervated by the obturator nerve as well. So we have some of the blocks like the suprainguinal fascia iliaca block, or you have the circumpsoas block, which I described a few years back, and this is in the Brazilian Journal of Anesthesia. You can have a look at that particular topic. So what are the hip analgesic compartments? If you're looking into the hip innervation and the related blocks, one is the lumbar plexus compartment, which almost everybody knows. The suprainguinal fascia plane, which also is now in practice, and the circumpsoas plane, which is a new block which is coming into practice. So if you look into this cadaveric dissection that we did in Graz in Austria, along with George Fiegel, you will find that you have a couple of planes here. Now, this is the psoas major muscle, and you have the psoas fascia going around it. You know that the femoral nerve and the lateral femoral cutaneous nerve, they leave the lateral part of the psoas major, while the obturator nerve, it will be running along its medial border. The second is the whole of the fascia iliacus plane here, which hosts the femoral nerve, the lateral femoral cutaneous nerve, as well as the articular branches. If you see these small ones, these are the articular branches which eventually penetrate the iliacus muscle, and they are relayed into the hip joint. And the third one is the chordatus lumborum, which has got the subcostal and the ilioinguinal, and as part of it goes into the lumbar plexus. So eventually you have these three planes. This is the fascia iliaca plane, that's the circumpsoas plane, and you have the chordatus lumborum plane. And you have three planes at disposal, which has got a couple of these nerves. And this is one which is used for the postoperative pain relief in hip arthroplasty. Now, what is the recent practice? So the recent practice is to have the articular and the cutaneous nerve blocks only. So it becomes a sort of motor sparing block, and most of the sensations are preserved. So we have recently described what is called as the perihumeral block, which we use for the distal third humerus, where you have the motor sparing as well as you have got opioid sparing. And we have started a new block that is called as the perishoulder block, or the anterior capsular shoulder block, which is yet unpublished. We have just finished a series of 5 cases. So these are what we call as the motor and opioid sparing nerve blocks. Now, what is the anatomical basis? You have this lumbar plexus, which extends from L1 to L4. You have the lateral femoral cutaneous, you have the femoral, and you have the obturator, all which innervate the hip joint. And you can block at the level of the roots, that's the lumbar plexus block. You can block at the level of divisions of each of these, which is the lumbar plexus as well. Or you can block at the level of the articular nerves. Now, this is a cross section again, which was obtained in the Anatomy Institute of Graz, along with George Fiegel. This is the iliacus muscle. That is the psoas tendon. This is the femoral nerve, what you can see, and this would be what you can call as the line. The most important thing, that would be the anterior inferior iliac spine here, the superior iliac spine here, This would be the iliopubic eminence, and this femoral nerve will eventually give its branches across these to the capsule. On the medial side, you have the obturator canal here. This is the obturator internus. You have the obturator nerve here, and it would then innervate from this part. And there would be one accessory obturator nerve which would lie here. So this would come directly from the lumbar plexus. So the basis of this anatomical basis for this block is to deposit the local anesthetic somewhere here on this line, so that you could get hold of these articular nerves. And I suspect that whether you really get these nerves, this is quite questionable, because we have done some cadaveric studies that I would like to reveal further. So eventually you have the femoral and the obturator nerve which innervate the anterior hip capsule. You have the femoral distribution which is homogeneous. You can see here it's all black, while here you can see it in various colors, which is the obturator nerve, and it supplies the antero-medial and the antero-inferior medial quadrants. Now, there could be some variations, of course. The nerves can come from the pectineal nerve. It can come directly from the femoral nerve. It can come from the accessory obturator nerve here. But the idea here on this line. So this line is very important. So the anatomical landmarks which are important are, one is the anterior inferior iliac spine, and the second would be the iliopectineal eminence. So these two are the most important things which to be looked on with the help of the ultrasound. So we are looking just into the anterior innervations and not the posterior innervations. Short in his excellent of anatomical basis of the articular nerves, the line on which these nerves they arrive and innervate the capsule, anterior capsule. So this is again the articular branches of the femoral, and the accessory obturator nerve would arrive from here. But this is the obturator canal, which I think in no way you can have this blocked, because these nerves they come from the medial side, so they may not be blocked. But these are the two important nerves, the articular branches of the femoral and accessory obturator nerve. So we have the bony target, we have the AAIS, and we have the IPE, and these are the neural targets, the articular branches of these. And these are the ones that you never see on ultrasound. It is just that you see this line and you inject along this line and you hope that your block would work. So this is how that you are going to propose your new technique. What the student of Peng did, this person, he introduced this particular block and he mentioned it very cleverly as a pericapsular block, called as a, and he had a sort of a non-homogeneous demography where you can have the intertroch, the subcapital fractures, and again some tumor here, and they were for a variety of surgical procedures where you have 20 ml, which was almost consistent, but you have in 4 you had bupivacaine and in 1 you had ropivacaine, and they have just done just 5 cases, and based on this they have come across this new technique without any cadaveric background or without any contrast injections. So what they proposed was you have to place the probe which is just close to the anterior inferior iliac spine, and then slide it a bit more medial, try to gain access to the femoral artery and this particular the contour there from the AIs to the IPE. The needle is brought from the lateral to medial, and once the needle is brought from lateral to medial, you deposit the local anesthetic just by the side of tendon here, so that the local anesthetic it blocks the most of these branches of the articular branches of the femoral nerve. They do mention that the local anesthetic has spread medial, but I suspect whether this part of the local anesthetic really is the one which moves from the lateral to medial as well. Excellent review of this article. From anterior spine to the AIS, and then a bit more medial. along this, and once you are aware that you see the psoas tendon, you place the needle just by the side of the psoas tendon. So remember that this could be a part of the psoas muscle. That is more the iliacus muscle. This is the femoral artery. And this is very much adherent to the psoas tendon. So I am not sure if you place the local anesthesia here, this would travel over the iliopubic eminence and block the obturator nerve. I am still not sure about this. So a cadaveric dye study where they injected 20 ml on one side and 10 ml on one side. And if you look into this, this is the whole of the iliacus muscle, and it's all stained blue. The femoral nerve is not stained, but it stains the accessory obturator nerve here. While the 10 ml, it doesn't stain the obturator nerve, neither it stains the femoral nerve. So what they mention here is Tran mentions that this has to be studied further, but I feel that the spread is more like the fascia iliacus when you use 20 ml. And this is what I exactly mentioned in one of my lectures earlier. So 20 ml spread at this point is just like a fascia iliaca block. It will block both the femoral and the lateral femoral cutaneous nerve, which travel here, and it travels that way. While the 10 ml, it is more consistent in blocking nerves. I'm not sure about it unless you do some of the cadaveric studies. So the entire clinical evidence of PENG block is based just on case series, that is postoperative pain, and there's a few case reports where they use for positional pain as well, and a randomized controlled trial between PENG versus no block. So this may not be a suitable comparison. You need to compare PENG with some standard block, maybe the lumbar plexus block, or it has to be compared now with the CP block, because the CP block is one which is now more commonly used for all hip arthroplasties. One of from Turkey, what she did was she injected contrast in at the PENG site, and with 20 ml, she found that it spreads to this extent, and it blocks almost the entire like the articular branch of the femoral and the articular branch of the obturator as well. So this is what she had proposed, and she came out with a significant cadaveric dissection. So this was 10 ml and this is 20 ml. So the 20 ml spread is of course more, and it goes more caudal, 20 ml spread, while the 10 ml spread is more cephalad. So this is a sort of three-dimensional anatomic schematic diagram, and she mentions about the anatomic barriers. Now this is one of the anatomic barrier, which is the pivofemoral ligament, while the blue is the iliofemoral ligament. So these two are the anatomical barriers. That is, when you propose that your needle has to be just lateral to the psoas major muscle, or this the tendon of the psoas major, it's going to be difficult for the drug to go and block the articular nerve. So that is what they have proposed. So what exactly more than 60 or 75, because of aging and osteoarthritis, there is a rupture of the bursa, there is degeneration of the iliofemoral and pivofemoral ligaments, and this is what is going to facilitate diffusion of the drug into the joint and as well as around the capsule. So one of the reasons why it could be effective in elderly patients is these two reasons, and the diffusion of the drug into the joint. So it becomes also not only pericapsular, but it also becomes intracapsular as well. So what do we do now in a clinical study? We compare. We are doing a prospective case series of PENG and LFCN, and we are using it for the proximal femoral nail fractures. If you can see that this is the psoas tendon, and the needle as it arrives from the lateral to medial, it pierces, but we don't pierce because this is the beginning of the psoas muscle. So we just try to be still more lateral at this point, and try to inject local anesthetic so that it spreads and blocks the femoral articular nerves. But for the drug to travel on this on the upside of this and block the obturator nerve, I think it's quite difficult. And we combine it with the lateral femoral cutaneous nerve. This was also mentioned by in one of his studies, and we use it for the just for the proximal femoral nail to the intertrocks and not the subtroch fractures. And I use 15 ml of 0.2 ropivacaine along with clonidine, and here I use 5 ml of 0.2% along with ropivacaine along with clonidine. Now, what we have seen so far, we have done 15 cases. This was at the time for right that we had done 7 cases. We had seen that the time to first analgesia was not great, and it lied anywhere between 4 to 10 hours. There is no statistic analysis for just 7 cases. The analysis was around 3 to 5. The rescue were in 4 blocks. There was no cordyceps weakness. Of course, there were no adverse events. But there was also no difference between the times which was spent in ICU and time which was spent in the hospital. So it did not affect much upon the total clinical outcome in this particular group of patients. Now, why did I mention about cordyceps weakness? Because if you inject very high volume of drug, it is likely to spread here, and this is what we have seen in some of the reports. And if you inject inside the muscle, it's also going to cause spread into close to the femoral nerve. So the ideal would be at this one position, which is lateral to the psoas tendon or even the psoas muscle, I would say. And this is the iliopectineal eminence, which we mentioned. That's the obturator canal. This is the. So would it work? So we did a cadaveric study along with Dr. Prakash from Mysore, from Nagpur, Dr. Pallavi from Pune, and Dr. Gupta is basically from Delhi, and she's going to help us in a study design. And we compared PENG with PENG and the CP block, and we found that the needle is somewhere at this point. If you can see the tip of the needle, this entire is the psoas muscle and the tendon, and this would be the tendon, and the needle is just very close to that. The entire methylene blue dye, it goes through the iliacus muscle, entire up to the iliacus muscle, so that it also blocks the nerves which are inside the iliacus, and they come into the and they form the articular branches. And when we dissected the iliacus away from what we found that it had affected the anterior obturator nerve. So definitely the anterior obturator nerve and the femoral articular branches of the femoral nerves got affected by the methylene blue dye. So what were the outcomes? So the outcomes of our cadaveric study was that in 1 of 12 specimens, the obturator nerve was soaked, and in PENG, none of the specimen, the obturator nerve was soaked. So this is what we had our interim analysis, though we have not made a full analysis of the outcomes. So my questions on PENG: is PENG a novel block? Now, being a pain physician, we have done this in the previous. We are very much conversant with these particular anatomical landmarks. For example, this is the LFCN, and this is the for the femoral articular nerve, and this is for the obturator articular nerve. So we are very much conversant with this particular anatomical landmarks, and we do it with fluoroscopy. So these are similar to what the PENG has described, just probably and they have defined cleverly anatomical landmarks with ultrasound probe, where we use this particular cool radio frequency for the for the hip joint, chronic hip joint patients who are contraindicated for total hip arthroplasty. And the outcome is quite significant. If you see this patient who received this full radio frequency, he can flex and extend his hip joint. He can do that. But when I asked about his pain, he said that he just has pain at the trochanteric site. Now, this is the site which is supplied by the femoral articular nerve. So we had to redo that again for this particular patient. At that point of time in 2016, this was also described with, we also did it with the ultrasound. We placed the needle and you can see this is the iliopectineal eminence. And I just placed the needle according to that and I injected some amount of local, but this was in the obturator foramen. So this anatomical landmark was not new for us at that point of time, but we never described it earlier. So is PENG block a reality for postoperative pain relief? Now, this is a very important article, and this article mentions the number of nerves per centimeter square. Now, if you see this from the skin is maximally innervated, and then would be the innervation of these particular structures. And these are the subcutaneous tissue, the superficial fascia, the deep fascia, the muscles, and the ligament of the capsule. But if you see the capsule, which we are more interested with, where we try to give the pericapsular nerve block, it is least innervated, the most least innervated. So it means that it might not produce that amount of pain than what these structures have been producing. So why do you target this when it would not produce much amount of pain? Again, if you see, these are moderately innervated, while this skin is highly innervated, and this one is poorly innervated, of which the capsule is one of them. And this is the one which we are targeting. Then why do we target that when it's very poorly innervated? So this is both in the living as well as in the cadaveric studies that they have seen the histological structures. Again, if you see here, so in this case, what I ask myself is, does the PENG affect these structures or they cover these structures? It will not. So the PENG block is restricted only to this particular capsule and the ligaments of the capsule and probably the tendon. I'm not sure about this. So what we aim here is that at this point is now what blocks would act in this particular areas. It would be the CP, it would be the circumpsoas, and it could be one additional block, the lumbar erectospinal plane block, which we also quite commonly perform. So is PENG block the answer for hip arthroplasty? It's a big question mark. I'm not sure about it yet. So do I recommend this block? So until further very high grade evidence studies are produced, and when you compare PENG with either the lumbar plexus block or the lumbar erectospinal plane block or the suprainguinal plane block, I wouldn't be ready with my answer. So for now, when I use the blocks for hip surgeries, in our institute, we use the suprainguinal fascial iliaca block and we use the lumbar erectospinal plane block. And we recently concluded one study headed by Dr. Bharati. I'm a part of it. And what we found that the lumbar erectospinal plane block is better than the suprainguinal fascial iliaca plane block. And again, it's very difficult to answer why this would be better than this for the lateral hip procedures. The circumpsoas plane block, which I have described, it covers almost all the nerves, the femoral nerve, the lateral femoral cutaneous nerve, the obturator nerve, and as well as the genitofemoral nerve, all the 4 nerves, because we inject inside the psoas muscle. So until you have randomized controlled trials, which will compare PENG with the lumbar plexus or PENG with the lumbar erectospinae or PENG with the suprainguinal fascial iliaca plane block, and we have those studies which will mention the importance of PENG at these blocks. So thank you very much for your kind attention. This is what I had. I thank Dr. Manisha as well as Dr. Avinash for this opportunity, and MSA as well. Thanks a lot.
Thank you so much, Dr. Sandeep. It was really an excellent presentation, and I'm sure that many of our listeners are going to have few or other queries on this topic. But before that, may I have the expert opinion of our both moderators, Dr. Bharti and Dr. Nasima, because everybody is trying these blocks nowadays and trying to give these blocks, and Bharti is already in the institutes, and just now Dr. Sandeep Diwan mentioned that she is also one of the part of the study that they are conducting at Sancheti. So, Dr. Bharti, madam, please.
Yeah, thank you for giving me the opportunity to participate in this symposium. Sorry about the delay in joining. Yes, as Dr. Sandeep has mentioned, we have been trying various types of blocks for our hip surgeries. Like he said, I still have hesitation for using PENG for total hip arthroplasty, the surgery. I tend to use PENG very routinely for like on arrival block till the patient is stabilized or optimized or investigated, especially the elderly patients. But I'm not still convinced that it will act for the surgical site pain. So the choice of surgical site pain management is something different, like the CFI or the LESP, the lumbar erector spinae. But PENG, it is wonderful in the sense that it does not produce any muscle weakness. The patients we have seen within an hour, within maybe 30 minutes of giving PENG to the fracture patients, they're able to sit up and they can move their leg, but they're pain-free. And that gives them the confidence, like they are going to be, they are going to come out of bed. You buy time by giving them PENG and reassure them that this works, we will take care of your pain, and the further management is going to be there. But beyond that, PENG definitely lacks the conviction that it can be used for arthroplasties or the open surgeries.
What you want to say is that it cannot be used as a sole anesthetic.
No, not at all. Not at all. Nowhere sole anesthetic or not even the sole analgesic for post-op pain management.
Yes.
No, not for surgery.
Yeah. Thank you so much. Nasima, madam, you want to make comment?
Add something.
Madam, it was an excellent, as usual, Diwan sir's presentation was excellent. And as always, his presentations are good, and he has done a lot of work on the cadaveric. But we have not yet used PENG here. We are not using it in our institute, but we are giving for analgesia before surgery or before giving regional anesthesia. We are using femoral nerve block frequently, and we are very happy that patients are very comfortable if you give femoral nerve block before giving position to the patient for spinal or epidural. So we are very happy at present with the femoral nerve block. And regarding PENG, I had attended the Prague conference, CME in Pune, just few months back. That time there was a lecture on the PENG also. But we have yet to use, so I cannot give much of comment on the PENG as such. We have not yet used it. Bharti madam is the best judge. She must have used it in her institute.
Yes, we have been using it. The advantage of PENG over femoral nerve block is femoral will always have a quadriceps weakness, which is not there in case of PENG. If you are very, very particular about putting your needle below or just lateral to the psoas tendon, that is the best place, and your drug will never go above the plane of the iliopsoas, and that is the place where your femoral nerve is. So you avoid femoral nerve, the quadriceps nerve block, which is always there with femoral nerve block. So the patient can have it's a dynamic pain relief. The patient can move the leg, but he is pain free. That is the reason it's a better option to femoral nerve block even for positioning.
Yes, motor sparing effect.
Yes.
Yes. Okay, thank you, madam.
We'll take the questions from the chat. There are questions in chat box. Avinash, there are questions in chat box. First, there are questions. We will take them first, and then we will make it open to the audience. There is a question, Dr. Sandeep Diwan. What is your opinion regarding suprainguinal FICB as compared to PENG block for hip?
Yeah, so the the SIFI block as compared to the PENG. So we did this study, and interestingly, one of my colleagues, she's from Nagpur actually, Dr. Rasika. So what she mentioned is that she combines the PENG along with SIFI block for an extensive blockade of the hip joint. Never, you don't mobilize this patient, so there's no problem about quadriceps weakness as suggested earlier. So if you compare these two blocks, the PENG and the SIFI, they are far apart. So the PENG is just the articular and cutaneous nerve block. It's very, very localized, and it's yet still to be studied extensively. Apart from that, the SIFI block has been extensively studied. We have done several contrast studies ourselves. We have done cadaveric studies ourselves, and we have seen the extensive spread. If the surgeon and the patient has no problem of getting out of the bed as early as maybe 12 to 14 hours, I think they should work. The CP should work. We have seen excellent results with that. In fact, in our institute, we go still further ahead, and we give the LESPB, the lumbar erector spinae plane block, which would be even more better than the CP because it blocks the components of the lumbar plexus as well at its root level. So I think if you go more proximal, LESP, though the spread is just 16%, as has been mentioned. So I think the algorithm would be, for us, it would be LESP better than the CFI, better than the PENG. Probably now we are also have uploaded for the CTRI, we are going to compare 3 groups. We have the PENG block, we have PENG with CFI, and we have just the CFI block. So we're going to try to compare these 3 in future for the randomized controlled trials.
Thank you so much, Dr. Sandeep. Are there any questions? Everybody's.
Can I just come in, Manisha?
Yes, sir. Yeah, sure, sir. Please.
I think people do the PENG block in a very wrong way, and this has been also mentioned in a review by PENG himself. The way people do it is actually, not the right way. If they do it in the right way, it does. And my experience has been we have used PENG block for day case because that's where you want sort of muscle sparing blocks. And I have actually videos where patients, my own colleague's father, who's walking within, he's actually walking home within 6 hours after surgery, and enjoying a meal, a heavy meal in the evening. So it works. It's only when you start thinking about GA with blocks and you want perfect analgesia. So these patients they have spinal anesthesia with plain bupivacaine, have PENG block, but also the other thing we do is we do allow our surgeons to infiltrate. So local anesthesia infiltration, or LEA, is also used along with it. And understandably, the hips are far less painless. Okay, but that it is less painful. The hips are less painful than the knees. Knees are a lot more painful. So these patients actually do better with PENG block and local infiltration analgesia.
Shiv sir, I want to ask how PENG is given wrongly. I mean, where do you?
Well, that need to be demonstrated on a video. You need to actually see a video, proper video of a proper PENG block to understand why people actually do it wrongly. And if it does done properly, it's not actually. There is a capsule. Yeah. There is actually an area where you need to actually deposit properly, and then you actually get a good spread. And it does actually help in analgesia.
Mm-hmm.
Sure, sir, you are mentioning that it is better block for post-op analgesia. That's what I could get from whatever you said.
No. So you have to look at whether, like I think it was rightly mentioned, whether you're going to mobilize the patient or not. So if you're planning to actually mobilize, like for day case patients or day case hips, they're going to go home within 6 to 8 hours. They're home. They need to actually have physios. They need to be able to actually do physio. And then only they are sent home. Then in those cases, you need to have blocks like this, where there's no motor involvement at all. But you also get good analgesia.
Yeah. Thank you
Sir,
so much.
Thank you.
Sir,
Thank
one
you very much, sir.
question to Shiv sir.
Yes.
Just one question can I ask? Sir,
Please.
can we give a landmark technique for, can we use landmark technique for PENG block? Because we don't have USG machine in our institute. So can we do it?
People,
Anyway,
people
we can
have tried
start.
to it. Yeah, people have tried to describe it, but I don't think you can, because the way, like I said, you need to read the review by Peng himself, how people likely, if I find it, I will likely put it up on the group, the anesthetist group, and I will likely, I'm actually talking about it in London day after tomorrow. I'm actually talking about the advances in regional anesthesia for orthopedics, giving another lecture at the Royal College of Anesthetists day after tomorrow. I'll be talking about that. So if I record it, I will likely present it as well. Landmark guided PENG block, I think you won't get it in the right place. You're more likely you go into capsular deposit somewhere. I don't know. I don't think you can be perfect. There is no particular landmark you can use where you say, okay, fine, you are going to be next to the psoas tendon. Sorry.
No problem.
Any more questions? Any more
I think
questions
no.
from the audience?
Okay.
Okay.
Anybody want to ask any question? Please unmute yourself.
Yeah, there is a comment that I routinely use PENG block for hip surgery. It provides excellent intra and post-operative analgesia. Yeah, thank you so much, Dr. Pramod sir. If there are no more comments, I think we should move forward for the next interesting debate. Thank you, Dr. Sandeep, for excellent deliberation. It was as usual, the Zoom platform was full for your presentation. Thank you so much.
Thank you very much, ma'am. Thanks a lot, everybody. Can I take your leave?
Thank you. Thanks a lot.
Thank you.
Thank you, Divan sir. Thank you very much.
Thank you. Thanks, Avinash. Thanks a lot.
So let's move on to our next important debate for today. And I take this opportunity to welcome to dynamic and excellent speakers of Maharashtra State Chapter ISA, Dr. Pallavi Bhutiani and Dr. Preeti Kanojia. Let me introduce Dr. Pallavi. Pallavi has done MBBS from Mirrors and MD Anesthesia from my place, Solapur. I've seen her in her postgraduate days in the Department of Anesthesia. She's a governing council member of Maharashtra State Chapter ISA, has presented many papers at national conferences, also at the Year of Conferences, and has a lot of publications. She has special interest in regional anesthesia, obstetric and pediatric anesthesia. She's a founder member of PROACT Pune, and she has delivered lectures and chaired sessions in various conferences at CME. Welcome, Pallavi.
Thank you. Manisha madam, thank you. Our next speaker is Dr. Preeti Kanojia. Madam is consultant anesthesiologist in and freelancer private practitioner in Mumbai. She done his MD at GS Medical College and KM Hospital, Mumbai. She is awarded best paper at in consultant category in Isakon, Maharashtra, Sangli. She has done fellowship in laparoscopy anesthesia in London and in France. She is a certified care provider of also and faculty at Chennai International Conference. She had public awareness prize in Isakon, Maharashtra, Shirdi, and in 2018 World Restart a Hard Day, she had 36 continuous ULS sessions with 44 trainers training over 10,000 persons at one center. And for that, she got a national award. Then she's a IRC certified COLS, BCLS, and CCLS trainer, scientific secretary of ISA Boroli branch, and also delivered lectures and chairing scientific session at various conferences and CME. Welcome, madam. I request. Yes.
Yeah. Let Pallavi start her presentation.
Yes, I request Pallavi to start the presentation.
Is my screen visible?
Please
No,
share again.
share again.
Oh. It's visible now?
Yes.
Yes.
Um,
Make it full screen.
yes,
Full
yes.
screen.
I'm doing it.
Yeah.
Now it is visible?
Yes.
Yes.
Yeah. Good evening, everyone. In today's pros and cons session, I'm talking in favor of regional anesthesia prevents post-operative cognitive dysfunction. Is my screen moving?
Yes, moving.
Yeah.
Just scroll once.
Excellent.
Yes. Okay. It's
Decline
okay.
in cognitive function after surgery and anesthesia is common problem, and it affects the various domains of cognition. It has a serious impact on the life of elderly patient, as it may stay for many days to weeks to maybe for many years, and it is associated with increased morbidity and mortality. It seriously impacts the quality of life of a patient undergoing surgery. It delays the discharge of patient and thus has an increased burden on the family and society. And in some patients, it may develop into the permanent cognitive impairment. The incidence of POCD is very high. It is almost 25% at 1 week, and it gets reduced to 10% at 3 months. And in cardiac surgery, it is even double. These are some of the risk factors associated with the POCD: advanced age, pre-existing cognitive impairment, low educational level, extensive surgery, and duration of anesthesia are some of the key factors for occurrence of POCD. The exact mechanism for its occurrence is actually debated, but till now, neuroinflammation is widely accepted mechanism or pathophysiology for its occurrence. It says surgery or trauma is associated with widespread peripheral inflammatory response, and it causes CNS inflammation by disruption of blood-brain barrier, and this is responsible for occurrence of POCD. This is an article questioning the relationship between the anesthesia and occurrence of post-operative cognitive dysfunction. But there are numerous studies available, and it shows exposure to specific anesthetic agent intraoperatively or physiological changes associated with anesthesia are associated with increased risk of cognitive dysfunction. So anesthesia is identified as a modifiable risk factor for occurrence of POCD. So next question comes, is there any role of choice of anesthesia on occurrence of POCD? So there are many studies, systematic reviews are available in the literature which compare general anesthesia with regional anesthesia on the occurrence of POCD. And many have reported that general anesthesia is associated with increased incidence of POCD when compared with the regional anesthesia. This is a very famous study from 2010 comparing the general anesthesia with regional anesthesia on the occurrence or incidence of POCD. Here for the regional anesthesia, they have selected neuroaxial blocks as well as peripheral nerve blocks and local infiltration. And they concluded general anesthesia, when compared with others, it increases the risk of development of POCD, and they also advocated the use of regional anesthesia whenever possible, especially in the vulnerable group. These are some more studies comparing general anesthesia and regional anesthesia from the recent journals of anesthesia, and they conclude with the same results that regional anesthesia decreases the risk of POCD. And it should be preferred over the other anesthetic techniques, especially in the elderly patients. Furthermore, they say memory, language skills, and visuospatial functions are better preserved with regional anesthesia. But it is very important to know how actually regional anesthesia prevents POCD. So it avoids exposure to many anesthetic drug and its effect on the central nervous system. It gives best post-operative pain control, so sparing the opioid effects. Regional anesthesia is associated with less stress response compared to the other techniques, also causing less inflammatory response. And these are the main reasons for the prevention of POCD with the regional anesthesia. Apart from this, there are many factors affecting POCD like anxiety, depression, sleep disturbances, and which are better taken care of in regional anesthesia. Regional anesthesia is associated with less complication. Patient can be ambulated early. Patient satisfaction is more with regional anesthesia. So all these factors together or maybe individually helps or contributing in prevention of POCD. Regional anesthesia associated with lower VAS scores, reduced level of inflammatory markers, so it has an effect on improvement of the early POCD. It is a common practice to give sedation along with regional anesthesia, and sometimes the sedation is so deep, and when it is monitored, this level consistent with GA occur in elderly patient, and this actually eliminate the benefit of regional anesthesia in POCD. And it is also said that light sedation reduces its incidence almost by 50%. But there are also other studies saying there is no benefit of regional anesthesia or general anesthesia on the occurrence of POCD. But when these studies are analyzed properly, there are many confounding factors found. There are multiple flaws in methodology. There is heterogeneity in the neuroassessment test or the timing of assessment. There is no consistency about the sedation use along with regional anesthesia or type or doses of general anesthetic used in GA group. Also, patient factors and anesthetist ability to manage anesthesia are also found to be important confounder factors. So when these factors are corrected in this study, I'm sure the regional anesthesia will be better in terms of prevention of postoperative cognitive dysfunction. Now let's see the other side of coin. General anesthesia is associated with administration of many agents, endotracheal intubation, sometimes facing with difficult intubation scenario. As we all know, general anesthesia is associated with more stress response, more complications. So all these factors altogether increases the stress and increases the inflammatory response. And as we have seen, this is the most important causative factors for the occurrence of POCD. This is an important article about the best practices for prevention of postoperative cognitive dysfunction. And they said these are the medication which needs to be avoided or to be used cautiously during anesthesia, as it has a propensity to cause cognitive impairment. And for anesthesiologists, most important medications are sedative, anxiolytic, anticholinergic drug, opioids, steroids, skeletal muscle relaxant, and all these drugs they say needs to avoid. And these are the main drugs we are using in general anesthesia. And the only drug they say it is helpful in prevention of POCD is dexmedetomidine. They also come up with the recommendation for optimizing the brain health postoperatively, and they say avoid all these drugs mentioned for its effect on the CNS, and to avoid the effect of all these drugs on CNS, titrate the MAC, titrate the anesthetic administration with the EEG based intraoperative brain monitoring. And also MAC of the agent should be adjusted with the age so that the overdosing will not occur and this will not affect on the brain and occur, has an effect on POCD. When compared, propofol is appeared to be better in prevention of POCD compared with the ceocurine, because the inhalational anesthetics has a more inflammatory, associated with more inflammatory response, as well as it has a neurotoxicity potential. So I have already explained all the facts about the regional anesthesia and general anesthesia, and I think you all are smart enough to wisely choose. Thank you.
Thank you, Pallavi. Thanks a lot. Yes, we are quite able to prove that regional anesthesia prevents postoperative cognitive dysfunction. Thank you very much. Be prepared now. You have to speak again for the counter debate.
Yes.
So now Preeti, your
Dr.
job
Preeti.
is really become difficult. So let's listen to you now. Regional anesthesia do not prevent post-operative cognitive dysfunction.
Pallavi needs to stop sharing her screen.
Yeah, she has done that. Pallavi, stop sharing your screen, please. Preeti, you can share the screen now.
Ma'am, I'm just doing it. Is it visible now, ma'am?
Yeah, we can
Yes,
see your
please.
CV. Yeah. Go on to the
Okay.
next slide.
Yes.
Yeah, if I may begin. A namaste to all my dignitaries of Maharashtra State Chapter of ISA, chairpersons, moderators, my co-debater, Dr. Pallavi ma'am, seniors, and my dear colleagues. I shall be refuting Dr. Pallavi's charges and saying, no, regional anesthesia does not prevent POCD. How does it feel to be confused by confusing an already confused person? Leads to a lot of confusion, doesn't it? Let me ask you a few quick questions before we jump into the topic. How many of us give standalone regional anesthesia to pediatric patients? How many of us provide exclusive regional anesthesia to our geriatric patients? How many of us have heard the following phrase, he or she was never the same after surgery, or that he or she has lost their confidence after surgery? Quite common, isn't it? I want to bring this, even the media seems to have noticed it, for we have an article from 2018 from the Tampa Bay Times where Dr. Daniel Cole's father, an aged person, underwent a heart bypass surgery. And he said that he forgets things and will ask you the same thing several times. Mind you, Dr. Cole is a professor in clinical anesthesiology at UCLA and has been a past president of the American Society of Anesthesiologists. He never got back to his cognitive baseline. This is what he says. In India, probably we would say he's gone into Gajni mode post-surgery. This gentleman most likely has post-operative cognitive dysfunction. My aim today would be to present a simple argument at the end of which we shall try to find out what works best under a given set of circumstances. What are the problems faced by our pediatric and geriatric patients? I chose these two ends of age groups because these are the ones that will commonly present to us as post-operative cognitive dysfunction. They are cranky, uncomfortable, in pain, and extremely thirsty. You are a stranger to them. They do not trust you, and they need familiarity in their lives. How do others around them perceive it? Post-operatively, he or she was never the same after surgery. In children, it presents as behavioral disturbances and scholastic changes. What are the common types of the POCD? How do we see it in layman's language? There is a significant decline which will be seen in hospital by the patient, the caregivers, relatives, or nurses. Or it could be subtle, which remains unnoticed until after discharge. Memory disturbances, difficulty in processing information may also be one of the some of the presentations. Here I wish to emphasize that post-op delirium and post-operative cognitive dysfunction are two distinct entities. Delirium is very short-lived. It is seen in the hospital, seen immediately post-operatively when the patient is waking up. That is the commonest time you see it. Whereas cognitive dysfunction can appear or start appearing up to a week after the surgery is over and could have a lasting effect on the person's lifestyle for years to come. Why is it important? Because it is commonly associated with permanent disability, leading to a definitive decline in the standard of living and an increased mortality. How do we induce these patients before we give regional anesthesia? For children, we commonly use oral or intramuscular pre-medication, or we use mask induction. For the elderly patients, we use sedation. Earlier, we used to use benzodiazepines and opioids, whereas now dexmedetomidine has become a game changer. Now here again, the aim is to keep them immobile while we poke around with the needle. Both of them are not going to listen to you if you do it in an awake position. So you're going to give them something or the other. The earliest article I have presented is from 1995, where cognitive effects after epidural and general anesthesia in older adults for total knee replacement was studied. Now, this here, at that time itself, they said whether it is general or epidural, it does not affect the magnitude or the pattern of postoperative cognitive dysfunction or the incidence of major cardiovascular complication in older adults undergoing elective total knee replacements. Mind you, this was one of the largest trials done to date with more than a 99% power to detect any clinically significant difference on any of the tests. Coming to 2003 match, does anesthesia cause a postoperative cognitive dysfunction? This was a randomized study of regional versus general anesthesia in 438 elderly patients. Here also, they concluded that there was no significant difference found in the incidence of POCD 3 months after either regional or general anesthesia in senior citizens. December 2017. Avinash, sir, you are audible. Okay, December 2017.
Yes.
Again, they say that irrespective, or rather, even when you have had clinically normal patients where you say that they may not have had any cognitive decline before surgery, in spite of that, approximately 12% of these patients will still develop cognitive dysfunction after non-cardiac surgery. This is the same article that Pallavi has pointed out from August 18, postoperative cognitive disorders, whether it is delirium or it is postoperative cognitive dysfunction. The same thing in the summary, they have mentioned that there is insufficient evidence to recommend a specific anesthetic technique for the prevention of POCD. Coming to anesthesia essays and research is done again in 2018. Now this, we always quote Western figures. This is our own Indian figures. Here they studied patients above the age of 60 for elective total knee replacements. Here again, they said that POCD is a definitive entity. Mind you, in this study, they have done all cases under spinal anesthetic in patients over 60 years. There is no general anesthesia used at all. Even in these patients, they say that POCD is a definitive entity which can cause short-term and long-term cognitive effect in elderly Indian population undergoing total knee replacements. But here, they also mention that there are other factors like age, oxygen saturation, electrolyte imbalance, which are very important in those developing POCDs. 2014, this is an article from Neurosurgical Anesthesiology. They have mentioned that multiple clients, this was actually a literature review. They went through lots of papers. They tried to amalgamate everything, but they found a lot of conflicting reviews. Why? Because some studies were not double-blinded enough. Some places, post-operative decline had to be self-reported. The patients had to come back. Some places, some studies were not done in the pediatric age group. So they actually literally threw out a lot of research papers in this particular review. Anesthesia analgesia, April 2019, long-term neurodevelopmental outcome following general anesthesia in early childhood. Here again, they found a lot of contradictory findings, especially when children had to be anesthetized for repeated procedure, whether it was staged procedure or it was a repetitive procedure. So randomly allocating children to this group or that group was not very easy. So this was also not very confirmatory or specific. This was March 2022, the same article that Pallavi has mentioned, neuroinflammation. This is now a big game changer. They have found a definitive correlation between neuroinflammation and POCD. So what I'm trying to say here by this article again also mentions that it is not generally the anesthesia, but there are a lot of other factors, mainly surgical factors and patient factors. Surgical factors being the kind of surgery that is going on, whether there are the duration of the surgery, the kind of fluid shifts and fluid imbalance that is going to happen, the kind of acid-base disturbances that are going to happen, the electrolyte imbalance that is there, age of the patient, hypotension, the hypoxia that is there during surgery, all these are the contributing factors. So you cannot really blame one over the other. In conclusion, I would like to say that regional anesthesia may be used as one of the modalities to prevent the onset of postoperative cognitive dysfunction. It can, however, by itself also contribute to POCD. There is no statistical evidence to prove that regional anesthesia does not cause POCD. Thus, one cannot conclusively say without doubt that regional anesthesia does not cause POCD. Thank you.
Thank you. Very excellent presentation. Now, I request Pallavi ma'am.
No, I have to go ahead.
Priti, please mute yourself. Dr. Pallavi?
Yes, ma'am.
Yes. Counter
Yeah,
debate.
Dr. Preeti ma'am very well presented her point, but in my opinion, she has presented all the article which I have presented. And I already said there are many confounding factors associated with this. Whenever there are articles saying there is no difference between the general anesthesia and regional anesthesia, when you go into detail and assess it properly, there are many confounding factors found, and there is no common consensus. So these articles are not, and there is nowhere mentioned that instead there are many articles they have mentioned regional anesthesia is better compared with the general anesthesia, but in this article also it is nowhere mentioned that general anesthesia is better in prevention of post-operative cognitive dysfunction. And one point I agree with Dr. Preeti ma'am, that studies has proven that it is not only the anesthesia which is responsible for the occurrence of POCD. There are many other factors like surgery, other patient factors, also drug reactions, and all other factors are also associated with the occurrence of POCD. But if I ask all of you present here, if your nanny or grandpa is admitted with a fracture femur, what anesthesia will you give? And I think the answer lies here only. Thank you.
Yeah, excellent counter debate, Dr. Preeti, Dr. Pallavi. Yeah, Preeti,
Thank you,
please
ma'am.
go ahead. Unmute yourself,
Yes, ma'am. I need to share my screen again.
please.
Please share.
This. Yeah, is this seen now?
Yeah.
Yes, yes. Yeah. Please
Okay.
continue.
Now here again, I would like to put up an article by Dr. Daniel Cole himself. That earlier article was 2018. This is last year, September 7. Now he talks about neuroinflammation right here. He says it is a result of perioperative stress, vascular disorders, or the acceleration of neurocognitive decline. 65% of patients will experience delirium, and 10% of those may develop long-term cognitive decline after non-cardiac surgery. Now, these complications may be associated with longer hospitalization, more days on the mechanical ventilator, and functional decline. Now, here, what is important? See, we have a lot of risk factors and targeted intervention. Do you see anesthesia in this list? No, right? So if you take care of all these things, probably you don't need to bother about anesthesia. It's very common in our country, it's very common to blame each and every little thing on anesthesia. Patient doesn't wake up, maybe anesthesia. Patient has a problem, maybe anesthesia. It's come down from the surgeons, and now it's become so ingrained within us. If anything goes wrong, it is anesthesia. So we are trying and scurrying around trying to be on the defensive, when we have to say, no, my anesthesia, whatever it is, I'm an expert in my field. I know what I'm giving. Whether I'm giving general anesthesia or regional anesthesia, the choice is mine. I will handle the patient confidently, and I'm capable enough to do that. If you have an iota of doubt, you can call somebody else to help you out. There's no harm in asking for help. And definitely, there are people who are scared of general anesthetics, not necessarily anesthesiologists. There are surgeons. Please don't give general anesthesia to my patient, give regional. I'm happy with your blocks. They work perfectly fine. Post-operatively, patient is good. Now, I'm telling you, in patients where I have not been able to give regional anesthesia for whatever reasons, whether it is a skin condition or there has been surgery at the operated site, or the patient is not cooperative, not keeping the catheter in, pulled out the catheter. In these patients, even IV regional anesthesia, or sorry, even IV and this administration of multimodal analgesia works beautifully. So this is the era of multimodal analgesia, or multimodal anesthesia, as we like to call it. You give multiple drugs at low doses, keeping the side effects to a minimum, and the patient very comfortable. All the surgeon wants is a quiet patient post-operatively who does not keep ringing the bell and disturbing the staff nurses. So if you can manage that, it doesn't really matter what kind of anesthesia you're giving. Now, surgeons and anesthesiologists, here in conclusion of this particular article, surgeons and anesthesiologists should assess, discuss, and optimize the associated potential risks for each patient before surgery. Best practices and interventions can begin before surgery and extend well into the recovery or the perioperative period. To be most effective, these strategies will require family engagement and the involvement of interdisciplinary healthcare team and comprehensive systems of care. So rather than blame ourselves or our anesthesia for the outcome, I think it's time we opened our mouth, stood up for ourselves, and definitely tell people that there are other factors involved. And once we take care of them, I think our patients are going to be comfortable. So where you're doing, see, if you're putting me in a rural setup where there is no Boyle's machine or no suction machine, no proper monitoring, then I will choose regional anesthesia because I would think that is safe for my patient to keep the patient awake and complaining. Put me in an institute where everything is available. I don't think it matters. So we have to really bother about getting our infrastructure into place rather than blaming our anesthesia for the setbacks or the poor whatever review that comes from our surgical colleagues who have zero interest or knowledge about anesthesia. Thank you very much.
Thank you, Preeti. Can you please stop sharing your screen? Yeah, but at the end of the discussion, as Anita said correctly, yes, we are also confused and really do not know what is the answer for this. So let's have expert opinion of our moderators. Dr. Bharti,
There should be one take-home message.
Yeah.
Yes.
Yeah.
Can I make a comment?
Yeah, please.
Yes, please.
I'm sure all of you must be doing hip surgeries, especially the partial hips or the total hips. Most of you must have been giving spinal or spinal epidural for these patients. How many of you have seen a severe bradycardia and hypertension when the femur is, they do the broaching of femur? I think all of us.
Yeah, so many times you come across that.
Yes. So this is precisely what we are trying to talk about. This may not be the anesthesia which is responsible for the postoperative cognitive dysfunction or even the delirium. There are so many surgical causes which trigger this event. There may be, especially in orthopedics, we see so many times the embolism is one of the most important factor for postoperative cognitive dysfunction. It may be fat embolism, it may be thromboembolic embolism, but this is one important point. There is nothing right or wrong. You need to learn how to combine what is best for the patient. Second thing, nowadays there is a lot of talk on frailty. Once you have the concept of frailty, your patient may not tolerate even a single dip of blood pressure. No hypotension is tolerated in these patients. So what are you going to do in such patients? If you ask me, my answer will be, this patient gets a very controlled minimal dose general anesthesia, control of airway, along with some modality of regional anesthesia. So now we do not have to fight whether it is regional anesthesia versus general anesthesia. Our aim should be how we combine the best in both the modalities for the safety and proper care of the patient and to have a proper outcome. When you think all these things, I think the battle finishes it. I must congratulate both of you. You have put on excellent, I should say, the debate, excellent points, but let us not fight. This is not a fight. You have brought in the good and the bad points of both the modalities. Wonderful discussion, and we must combine this to the best effect of the patient. Thank you.
Thank you, madam.
Yeah.
Manisha, can I come in?
Can I? Okay, sir.
Yeah, sure, sir.
I have actually been talking of POCD for a very, very long time. It used to be a very important question for the final FRCA as well. So I read extensively on POCD. There was actually, there always confusion. I think probably we confused it quite a few times, delirium with that. And that's some of the papers have actually confused post-op delirium with post-operative cognitive deficit. And I can understand that because there is actually no definition, proper definition of POCD. So you can't actually define POCD. It is only a clinical diagnosis where, like Preeti said, okay, that anesthetic president of ASA found his father wasn't the same again. It's the same thing. It is the children who actually give you the diagnosis. They say Dadaji, Nanaji, Naniji are not the same as they were before. That is what is post-operative cognitive deficit is. There is no definition. I mean, people have tried all kind of marker, like S100 and neuro whatever. They tried and they were found no marker. Also, even though it is said, okay, we need to keep everything under normal, blood sugar, blood pressure, oxygenation, but till now, there is no evidence that hypertension, hypoglycemia, any of this actually causes POCD in the elderly. I mean, we're talking about elderly patient basically. When you're talking about POCD, you're talking about elderly patients. But what has really proven to date is that bringing the patient back to their own environment, okay, that is day case surgery, is the only thing which actually prevents POCD, nothing else. Rest is about giving good anesthesia. Okay, one. The second thing is, we are debating about regional anesthesia and debating about general anesthesia. What's important about the role of regional anesthesia? And regional anesthesia not on itself, but regional anesthesia part of multimodal analgesia. Okay. That is what's important because it is a pain, post-operative pain, which is known to increase. Okay, POCD is actually, I think now is one part of something called perioperative neurocognitive deficits, or PND. They all encase everything, delirium, post-operative cognitive deficit, post-operative delirium, okay, or neurocognitive deficit, or NCD, okay, that is the other terms used. So perioperative neurocognitive disease or dysfunction encompasses everything. So regional anesthesia is just part of it. There are very few, I think there are quite a lot of things which are done so wrongly in India. Okay, everybody wants to give glycopyrrolate to dry secretions. Okay, very wrong thing to give for POCD. Everybody wants to give benzodiazepines to elderly. Very wrong. Okay. The good things which people have started doing, which I think Dr. Naresh Paliwal is here and has actually mentioned, is actually use of dexmedetomidine and ketamine. Right. Use of dexamethasone, which I've been nothing but talking about it since I don't know when even when our Facebook started. Dexamethasone, anti-inflammatory. If patients can actually have normal EGFR or renal functions, use of dexamethasone, use of non-steroidals, okay, regular paracetamol. These are some simple things, and avoiding unnecessary things is actually very important. Then coming to pelvis, regional anesthesia in India, yes, it is very, very important part because no one can actually give a proper anesthesia without good monitoring. And how many people actually even have end-tidal CO2, leave alone age-adjusted, end-tidal anesthesia concentration, ETAC. Okay, people likely don't even actually have that facility. So what is the best thing then? Then probably regional anesthesia. Okay, and again, propofol sedation or dexmedetomidine sedation, that is where the good thing lies. So we're combining with that is fine. That is actually useful probably. So I think the Indian studies will likely get you are going to get a skewed kind of, demography because there is no standardization. They're not actually even standardizing the age-adjusted MAC, the drugs they use for, everybody loves to give pre-medication, just give, even in peak of summer, people are giving glycopyrrolate because they want to dry secretion. Why? Hydration is very, very important part of preventing PND. Okay, if the patient is dehydrated, it will increase the incidence of perioperative cognitive deficits. So it's some very, very simple things which we can actually talk. I think like rightly pointed out by Bharti, it's not a debate. It's not a question, who is better, regional or thing. It is how we do them properly. That's what is important. How we do it correctly. In elderly, you can avoid a lot of medications can be avoided. Okay. That also reminds me of one more thing. There was somewhere mentioned about dementia. Okay. Then dementia is part of the perioperative neurocognitive dysfunction. It is not POCD, but some of the patients are on anticholinergics. Okay. Now those medications need to be continued. It has been seen that if you stop that, then the incidence of the POCD increases in them. Okay. Oh, I think went mute.
Yeah.
Oh, thank you. Thank you so much.
Okay, thank you. Thank you. Manisha madam, unmute yourself.
Thank you so
Yes.
much, sir, for your expert comments. Let's listen to Nasima madam, what she has to say on this.
Thank you, madam. Thank you, Shiv sir. Excellent presentation by both the speakers. And both have defended their topics very well. What I would like to say is POCD is multifactorial. It is not only anesthesia or the drugs which are responsible. Surgery and anesthesia, they are actually inseparable and they act as natural confounders of each other. What they have said that the damaged tissue at the surgical site, they act as a nidus for inflammation. This damaged cells at the surgical site, they go and they release some biomolecules which are high molecular proteins. These proteins attach themselves to the monocytes, and they cause certain changes in the nucleus of the monocytes, and they release the cytokines. So these cytokines like interleukin 1, 6, and necrotic factor, these are the responsible for the inflammation. So it is these inflammatory substances. Then they cause release of prostaglandins. These prostaglandins, they cause the damage to the blood-brain barrier. And then these cytokines and the monocytes, they enter the CNS and they cause inflammation in the CNS. That is, the neuroinflammation is the reason for the actual POCD. So it is not only anesthesia, it is also surgery, like what are the site of surgery, what type of surgery, the duration of the surgery, the blood loss associated with the surgery. Secondly, it is multifactorial, means the pre-existing conditions of the patient, which also depends on the age, sex, education factor, existing comorbidities in the elderly patient. So what they have said, you have to optimize the condition of the elderly. Many times we take fracture neck femurs and all these patients as emergencies without optimizing these patients. The elderly patients, they have a lot of metabolic abnormalities, electrolyte abnormalities are there, disturbances are there. And so we have to optimize these patients. It is a teamwork between the surgeons, the anesthesiologist, and we don't have it here, but the geriatricians should also be included. Geriatric anesthesia is also a different separate entity. It should be taken as a teamwork. Plus, intraoperatively also, it depends how the hydration of the patient is important. There is many times sudden blood loss in orthopedic surgeries, fracture neck femurs, and sudden hypotension is there. So what is the duration of the hypotension? That is also equally important. I had attended a certain, hello? Can you hear me?
Yeah. Please go on.
Madam.
Please go on.
I
had attended Bala sir's lecture. What Bala sir says that in geriatric patients, even under regional anesthesia, the intraoperative blood pressure should be, the mean blood pressure should be at par with the age of the patient. So if the patient is 75 years of age, then the intraoperative mean arterial pressure should be at par with his age, 75 or above. So there are a lot of factors which are responsible for the POCD in the post-operative period. Plus, they have said that avoid benzodiazepines if you are giving regional anesthesia to these patients. You can give a little bit, even dexmedetomidate is preferred to benzodiazepines. in the geriatric, but minimal dose, not much. And also post-op, there is a not new concept. We are all this thing is ERAS, that is early recovery after surgery. That is better, and it prevents less of POCD in the post-operative period. Even a good control of the post-op analgesia. That is also one of the factors which helps in reducing the incidence of post-operative cognitive dysfunction. I would just conclude in short is that the best treatment is the prevention and early recognition and management of the perioperative risk factors. And you should choose optimum surgical technique, short duration to reduce the inflammatory response, and adequate intraoperatively and post-operative control of the patient. So it is not that GA will cause, there are many studies which say that POCD is less in patients undergoing general anesthesia. Some studies say that POCD is less in patients undergoing regional anesthesia. So it is a controversial issue. All I can say is it is multifactorial. Surgery plus anesthesia, both are responsible, and the basic nidus is the basic pathology is the neuroinflammation, which is responsible for the POCD. And adequate management pre-op, optimization pre-op, intra-op management, and post-op adequate analgesia, very good analgesia will prevent or reduce the incidence of post-operative cognitive disorder in NLP patients.
Thank you so much,
Okay,
madam.
thank you.
It's very
Madam,
well summarized, and I think that should be the take-home message.
Yes, thank you,
Very
madam.
nice.
Is there any role of dexamethasone, not the dexmed, dexamethasone steroid in preventing the POCD as a
Yes.
prophylactic, or most
Yes.
of the anesthetists are giving dexamethasone as a anti-inflammatory in every case.
Can I take that question, madam?
Yes,
Yes, of course.
Anybody?
Yeah.
Yes.
Yeah. Now, when we are using dexamethasone, sorry. I use it practically for each and every patient, irrespective of whether my surgeon screams about patients' blood sugars going up and down. Sugars can always be maintained. When I'm giving regional anesthesia, I will use it for prolongation of action. When I'm using it for general anesthesia, I use it for post-operative nausea, vomiting. We all know it's an excellent anti-inflammatory agent. And under regional anesthesia, again, prolongation of action is always there. So yeah, I think it is an excellent agent that we can use for practically all patients. There's no problem at all. And this is the era of multimodal analgesia. So whether you are giving, now in the West, whether even if they give regional anesthesia, all patients generally or most commonly go under general anesthesia as well, along with regional anesthesia. So we should aim for multimodal analgesia where the surgeon is comfortable, we are comfortable, patient is most comfortable. You keep the patient pain-free, patient heals and tolerates your procedure better. They wake up faster, and a lot of other things like familiarity, that's most important to a senior citizen or even to a baby. You hand them their favorite toy. I usually ask my parents to get the child's favorite toy with them, so when the child wakes up, he or she sees that toy and is immediately happy. For senior citizens, again, a newspaper, presence of a proper lighting in the room, their dentures when they wake up, I tell them this will be by your bedside when you wake up. Or a clock in the room, a beautiful window from which they can look outside. Small things, presence of relatives all around, their loved ones all around. These are the things that are going to help prevent POCD or post-op delirium. Delirium, I'm not so sure, but POCD for sure, definitely. Thank you.
Okay, thank
Mani,
you.
just last comment. I think which Preeti just touched upon. I think one of the things we have seen that a lot of the elderly patients have hearing aid, and they have use glasses. You need to give that back to them as soon as possible. And that also brings to Pallavi's thing. In regional anesthesia, I tend to leave them on, all of them. Okay, if you have, that is the greatest advantage, I think, on the regional anesthesia side. Even if the patient is having sedatives, we even in our patients, we have, regional anesthesia, we tend to use propofol, low dose propofol for sedation as target control infusions. And I'll leave the hearing aids, glasses, everything on. So when they wake up, they feel normal. you can be shouting at them, and if they don't have their hearing aid, they can't listen to you. They can't open their eyes. Jokingly, recently I had a patient, elderly patient for vascular surgery, and I was shouting at her and she calling her name, and she wouldn't open her eyes. And then somebody said, well, this is not Marcia, this is somebody else. I was telling her name wrong. So, even with the good hearing, if you don't tell the right name, they won't. No, that's the important thing. Hearing aids and glasses, that is known. It is described in the literature. They give them back.
Yes, very true.
Walking sticks as well.
And early, and I think if
Comfortable, cozy room.
Yeah, and early feeding.
Well lighted. Yeah, well lighted.
Early feeds. That is one of the important things.
These are the criteria, madam, for ERAS, like early enteral feeding, early ambulation, mobilization.
Correct.
Keep the patient with their family members. That also helps in early recovery and reduce incidence of POCD also.
Yeah.
And what they have said, regional is not there is not one reason why we choose regional in elderly patients. It is many reasons are there why we prefer regional in elderly patients. But what they have said is regional with minimal sedation, no opioids, no benzodiazepines for these patients. So there are less incidence of POCD in the post-operative period. And multimodal analgesia, avoiding non-opioid multimodal analgesia is preferred. So all the criteria of ERAS, if we can apply it over here with the elderly patients, I think the post-operatives and the post-operative incidence is less. That's
yes.
I think here Pallavi, sorry, here Pallavi actually wins, because I'll tell you why. In Indian thing, like when you actually have the patients with regional anesthesia, and unlike, I think, like a lot of, I think it was mentioned by both Pallavi and Preeti, all the literature is from the West. And one of the problem with the West is that they do not actually have that kind of social support as we have in India. So if Dadaji or Dadi or Nana Nani actually has had an operation, a whole of the family will be there. Not what I think makes them feel they are surrounded by their own people. I think that probably leads to a much early recovery. And so I think there is a scope if we can actually standardize the kind of anesthesia we do, avoid wrong things. And if you were to actually study the Indian patients, I'm sure you're going to find that the incidence is probably much less than the Western population.
Yes,
I agree with you, Dr. Shiv. Yes, we do have an excellent support system. And in our institute, at least, we have started early mobilization. At least the partial hips, they walk within 4 hours of the surgery. The combination of maybe a low dose spinal and LESP most of the times. So it just builds them the confidence, that they are going to come out of bed. That is very important. Again, the role of PENG pre-operatively and post-operatively lumbar ESP whenever they get operated. But yes, the dentures, the glasses, the hearing aids, and the family around them. That is the trick to avoid post-operative cognitive dysfunction as quickly as possible.
What will be the ideal? Yes, sir. For urological, endoscopic urological procedures.
Yeah.
I think
I use simple analgesia. I don't actually use any for simple procedures like patient coming for cystoscopy, and even for the lithotripsy, laser lithotripsy. I just put the mask in with iGel. My usual combination is with paracetamol, like we described, some people call Shiv mix. I have paracetamol mixed with the magnesium sulfate and lignocaine, 100 milligram lignocaine. They get IV diclofenac is a very good analgesic for ureteric procedures. And that's all. Like, I let them breathing with low dose of an oxygen and sevoflurane with air. And all of them actually come out, bright. They have never seen any patient coming out agitated. If you have to use anything, do use low dose of either tramadol, 25 milligrams is more than enough in paracetamol. And you need to start that early. You have to start it because these procedures are very short, and the peak effect of paracetamol actually comes at 20 minutes. So if you're actually having problems, then use small dose of fentanyl. 20 mics bolus is enough. I tend to actually, if I have to use, I will dilute 100 mics into 10 mLs and then give them 1 to 2 ml boluses till the peak effect of the agents take place. I think the advantage we have, we actually tend to put the patient to sleep in anesthesia room, then take them to the theater. But in India, they already have patients in theater. So you don't get the time for the peak effect. So initial period, just use short acting and, fentanyl is a good agent for that.
Thank you, sir. Thank you very much.
And don't forget, diclofenac is a fantastic agent for, dexamethasone, diclofenac goes IV soon after induction. And if patients actually move, then other thing to use is just give boluses of small bowel propofol. There are actually studies where they compared sevoflurane and propofol with the TIVA versus the gas. And they found that the patients who have TIVA tend to actually do much better, slightly better probably, than those with the gas inhalation.
Yes, sir.
Okay, okay. Thank you. Any question from audience?
Any would like to comment?
Madam, in foreign countries, in sir is talking about UK, the surgeries and all those things get over very fast. So it is very easy to do cases under short.
You're absolutely wrong, Dr.
In
Naseema.
India, it takes time, sir. By the time we take the patient inside, the surgeon does painting, draping. It takes time. So giving, I think, general anesthesia for long, half an hour, 45 minutes for procedure like cystoscopy or small lithotripsy, I think we prefer usually in India, we go for regional anesthesia, low spinal anesthesia. And many of the times patients are quite post-operative very well. We haven't seen it. And then less of hypotension in the
Naseema, Indian surgeons are very fast rather than the Western surgeons.
Yeah, that's right. I agree totally. I agree totally. I think the Indian surgeons, I think, are far quicker than most of the Western surgeons.
Sir, ours is a medical college, so most of the PG
teaching
students are
institute.
doing all the
That may be the
procedures
reason.
in our institute. So it takes time.
Teaching
You
institute,
should
there
actually
might be
see
the
our
difference.
paperwork. You have to see our paperwork, actually, how much amount we actually have. So check in the anesthesia room, then, who checklist, then go inside, then who, okay, sign, time out, time in, time out. Okay, check out everything, everything takes a long time. It's much slower procedure. I think if you're looking at a procedure for even 20, 30 minutes, overall time is absolutely almost 1 hour from the time patient comes in to the patient is ready to get out. So we actually have waste a lot of time.
Here most of us are out of the OT before patient is out.
Yeah.
That's
why I said we have more time. So when I give paracetamol infusion, I know that it's by the time surgeon is actually ready for it, it's already peaked. It's around 20 minutes.
Yeah.
Okay, thank you. Any questions, please?
May I say something, sir?
Yes, Preeti.
Yeah, I would follow Shiv sir's technique specifically if my patient was on antiplatelets or blood thinners or something like that. In fact, I prefer to use regional anesthesia for my Euro procedures. Like I have a TURP tomorrow.
Yeah.
Now, it's not one size that fits all. So depending on the comorbidities that the patient has had, the age, the hydration, everything, that is connected to POCD, I'll have to see the patient and patient not yet admitted. So possibly coming up tomorrow morning for admission. So depending on that, yes. And yeah, if I get to do a PAC, then I definitely add paracetamol before, at least an hour before the patient walks into the theater or is wheeled into the theater. So yeah, it is an era of multimodal analgesia. I don't use an LMA so much for my elderly patients. I would either tube them or most likely give them some kind of regional anesthesia. Yeah, I mean that's where I would differ. But yeah, it's definitely worth learning. I have to work on my LMAs more now.
I mean, the use of supraglottic devices, you tend to require much less of anesthetics. I tend to actually keep them on MAC 8, that is age adjusted MAC of 0.7 to 0.8. I don't allow you to go to 1 MAC. So you don't, even with the patients who have not had regional anesthesia, They can very well manage with MAC of 0.7 to 0.8. But always keep a syringe of propofol, and if needed, just give a bolus, small bolus of propofol. So combined technique actually works really well.
Sir, what is the dose of magnesium you use
so there is,
with the paracetamol?
Yeah, so I tend to actually use smaller doses. So though it's different for different reasons, we used to use much larger doses, but for shorter procedure, just use 8 millimoles. Or for younger patients, especially elderly patients, they will have hypotension. You have to actually, know that the blood pressure will actually drop, especially if you actually give it very, very quickly. It does cause vasodilation. And that is dual thing, because the patients are fasted, okay, and you're not giving them enough fluids, you will actually see some amount. But don't be afraid of actually giving some amount of vasopressor. It is transient. It won't be that it will sustain. It usually happens in the first 10 minutes or so. After that, it is not sustained. So 8 millimoles is basically you're using just two of the ampules. Well, we have different, I think, it is 4 mLs.
Yeah, we have in milligrams, sir.
Oh, yeah,
We have magnesium sulfate ampoules in milligrams.
So that is 2
milligram, 5 milligram ampoules we have.
Yeah.
Gram.
Grams.
1 gram and
Sorry, gram.
It is gram.
Yes, gram.
100
Yeah, it is
milligram per
0.5 gram per ml.
Yeah.
So you are going to use 4 mLs of that, so 2 grams.
Yeah. Okay.
But in young patients, we actually use at least sort of 12 millimoles to 16, and even 20 millimoles. It's very good for patients who have cardiac arrhythmias or unstables, because it's a cell membrane stabilizer. So you get a much better rhythm. Patients who are in AF, sometimes I've seen patients, like if they're acute AF, converting back into normal sinus in front of me with just magnesium. There's something which are triggered. One of the commonest thing which triggers AF in the elderly is dehydration, common in patients who come with fractures. So bit of fluid and magnesium, that's it. You tend to actually put the magnesium into the bag of fluid and let it go. But when you're giving paracetamol, you're giving 100 mLs, it goes a little quicker, and you might actually find hypertension. And I think who was mentioning about the blood pressure? Again, there is no evidence actually. If you look at it, it's major swings, too frequent major swings, that is a cause. And it says that if you keep the blood pressure reasonable, it's fine. There's no absolute numbers. I think somebody said age of the patient equal to mean arterial pressure. I think that's a nice way of seeing it, but everybody will not actually have the same mean arterial pressure. Mean arterial pressure is going to vary. 75 age person will not have a mean of 75, not necessarily. A lot of these patients are already on.
So sorry to interrupt. Usually these elderly patients, they have got blood pressure on higher side, and usually their pre-op also mean blood pressures are on higher side, if you really observe. Because after I got this from Bala Venkat sir, he had taken a lecture for us on regional, and he had mentioned that he has some documentation about that also. So he has said that try to keep the mean pressures in geriatric patients above 65 and 75 to be almost at par with the age of the patient. That helps a lot in the post-operative period, and it reduces all the delirium and all those things. Because there is in geriatric patients undergoing ortho surgeries, there is sudden hypotension many times, there is sudden hypotension. Then, so you try to maintain as far as possible the BP on higher side, mean arterial pressures on higher side.
If he comes to my theater, then he'll have a heart attack then. I allow my blood pressure patients to actually go down to 55, 60, mean of 60. I deal with a lot of elderly patients because I do orthopedics and vascular surgeries. If he actually sees my patient, he'll have a heart attack then. Because I do not. And a lot of my colleagues do drive patients with metreminol, infusions. I think I have never in any of my patients, even for my carotids, I do not actually drive, even carotid surgery, carotid endarterectomy, don't drive. Patients themselves will actually. Intraoperatively, if you're under anesthesia, your CMRO2 is markedly reduced. If you give good anesthesia, your oxygen consumption by your heart is reduced. You reduce your CMRO2 significantly under anesthesia. And if you can actually, if you monitor the BIS, you give them 20 milligrams of propofol, the BIS score will actually almost go to almost 20 or 0. So there's no brain activity happening. Well, nothing can take away it is called the housekeeping. Housekeeping actually requires the only thing which reduces the brain activity for housekeeping is lignocaine. So if you are using lignocaine infusion, your anesthesia requirement actually goes down markedly. So BIS scores will actually drop significantly. I have seen with BIS scoring, if I actually used blocks, I find it difficult to actually even keep the BIS score to around 40 because there is no stimulation going on to the reticular endothelial system, and you can actually reduce. Even if I can reduce the MAC to 0.6, nothing, the BIS score doesn't actually go up. And then the patient will start coughing because you need at least MAC of 0.7 to 0.8 for patient to just tolerate the airway. Blood pressure has not been shown that it need to be. The reason that you might be right in that, or Bala might be right on that, in Indian population, because a lot of them are not under treatment. So they are going to see, you see the alpine anesthesia, or we call it as the roller coaster anesthesia, mostly in patients who are not on treatment. A lot of elderly patients in India are not, actually they are undiagnosed diabetics and undiagnosed hypertensive. And that's why he's probably right in that. But otherwise, like in our population, because patients see the GP, a lot of them are on treatment. So it doesn't probably matter to us. So yeah, you're probably right in saying that, fine, we need to maintain them more because you're going to see a lot of screens.
Yes, sir. In UK, every 6 monthly, each and every person is getting checked in UK.
Yeah.
You have that general practitioner system. In India, many times during our pre-anesthetic evaluation, we diagnose these patients as hypertensive, diabetics, and just 2 or 3 days before surgery, they are started on antihypertensives and anti-diabetics. So in India, many a times we are the anesthesiologists who are diagnosing them as diabetics and hypertensive. So maybe he has got evidence, and he has said that in elderly patient in our Indian population, we should keep it. So that he must be having his evidence on documentation.
No, that's why I said if they're patient
maintaining it throughout, and I have seen, I am doing that, practicing in my institute, in my theater, that I usually keep it at par with the age of the elderly patients, and post-op my patients are really fine. We go and see them in the post-operative period, they are doing absolutely fine. I mean, even POCD, what we are talking about, I don't think I have seen any patients in the post. Maybe we don't follow them after 7 days.
I think that is a wrong conception. Doctors do not diagnose POCD.
No.
Okay, what you're talking about is delirium. Okay, POCD is diagnosed by the relatives, not by doctors. I think that is the difference. Doctors diagnose delirium, patients' relatives diagnose POCD. It's always the children, the grandchildren who will actually diagnose POCD. They'll say the grandfather, dada, nana, nani is not the same as they were before the operation. That is a diagnosis of POCD. So doctors cannot.
So we never follow the patients as an anesthesiologist. We never come in contact with the patient after 3 weeks or after 3 months or 6 months. So usually only the surgeons must be getting this thing from the relatives that he is different. But as an anesthesiologist, we don't come in contact with these patients afterwards.
So what we look at is more of the, like I said, is perioperative neurocognitive deficits, which includes other kind of neurocognitive deficits or dysfunction, more towards delirium. Okay, that is the main thing which we actually tend to confuse. That is our diagnosis, and that's what we can treat.
So that's why it's a nice criteria. We cannot apply it to the patients in India, because one of the surgeons in my operation theater, sir. One of the surgeon in my operation theater, he was arguing with us that according to NICE criteria, you are not supposed to do so many investigations. But that time I explained it to him that, sir, in UK, they are getting followed every 6 monthly, whereas they are not getting followed in our India. Many times we are the people who are diagnosing. So that's why many of the NICE criteria, we cannot apply it in our Indian scenarios also.
I agree totally with you. I think it is the first time the patient would probably have their investigations done, a blood investigation or ECG or things. So I think the criteria should be totally, I think, but then ISA, I think, has recently come out with those guidelines anyway, isn't
Yes,
it?
sir. Yes, sir.
So you'll have to follow whatever the ISA says now. Otherwise, Manisha will get upset.
Nice, sir. our ISA is doing excellent job, sir. National as well as Maharashtra State Chapter ISA, they are doing excellent job, I would say. And
These are important for your medical legal purposes. They will save you.
Yeah,
Then
the
you say
guidelines
you
will
follow
save
the
you.
international
Yes.
guidelines, and they won't. But you say these are national guidelines, and that's what we have followed. Then you will be fine with that.
I think
Okay.
we had enough discussion
Yes, enough
and
discussion.
great inputs by all the seniors as well as Shiva sir.
Thank you very much.
Yeah.
I'm very. We are very lucky to have today. We have Shivkumar Singh sir with us, and for his. I am very much thankful for his expert inputs and comments. I'm also thankful to Dr. Sandeep Diwan for his excellent presentation as usual, and MSc Maharashtra State ISA also thanks Dr. Pallavi and Dr. Preeti ma'am for their excellent presentation and debate. Thank you, Dr. Bharti madam and Dr. Nasima ma'am for moderating today's session. Thank you everyone who joined today. It was almost full. The Zoom was full, more than 100. And YouTube, we don't know the exact number. So it was a full session today. Thank you very much.
We must say as usual. The session
Yes,
was full.
yes.
Yeah.
Yes, we'll meet again in next month in master class. Thank you very much. Good night.
Thank you, Katkade sir, for joining. Thank you so much.
Yes.
Can I talk
Yes,
for
sir. Yes, sir. Please.
Yes.
Lots of patients. My first feed is vanilla ice cream. Before we conclude, because vanilla ice cream has a mood elevation, it is and it is an antacid. It elevates the mood. It gives enough calories, and the patients are very comfortable too. So they don't feel thirsty. They get a hyperglycemia. They get a mood elevation, and it is antacid too. Thank you.
Sir, which drug?
Thank you. Something new.
Vanilla ice cream.
Okay.
Vanilla ice cream.
Or if you have children, you ask.
I asked about drug.
Children used to get it after their tonsil operation, isn't it?
Yeah, and patients are sick of hospital food. Patients are sick of hospital food. And if you have a child coming, you ask him what flavor you want. He will say strawberry, and you just ask the parents to get a candy for them. They are very happy. Thank you.
Wonderful.
Vanilla was wonderful. And I had an international patient who come for cosmetic surgery. She was sick of Indian food. And the moment she got a vanilla ice cream, she felt so comfortable. It was wonderful.
Thank you all.
Yes. Thank you.
Thank you, sir.
Thank you, Manisha madam. Thank you, Avinash sir. Thank you, Shiv sir.
you.
Sir, sorry for arguing with you, but these are the facts what we also.
Thank you very much. Thank you.
It was a
you.
debate again. The discussion was also a debate. Yeah. Thank you so much.
Thank you, madam. Thank you, sir.